Hello, my name is Daphney Ayinde. I am a DNP student at the University of Maryville, and this is my scholarly project, Implementation of Postpartum Depression Screening. My committee consists of my chair, Dr. Jennifer A. Brunworth, and my committee member, OB-GYN, Dr. Joy Pivito out of Dallas, Texas. At a clinic located in the southwest region of the United States, no routine screening for postpartum depression was found. To address this issue, in collaboration with the providers, the clinic manager, and the support personnel, a quality improvement project using current practice recommendations to implement routine postpartum depression screening was executed. The overall aim of the project was to facilitate early diagnosis and treatment of postpartum depression by providing postpartum depression screening to all women at their 6-week follow-up visit, thus leading to improvement in the overall health of the patient. So why is this relevant? Postpartum depression occurs in 1 in every 7 women after birth in rates ranging from 8% to 20%. The birth of a baby can be one of the most exciting times of a woman's life. Yet, the fear of the unknown, the presence of the unfamiliarity, and the mix of powerful emotions may result in the unexpected depression. The National Institute for Healthcare Management has reported that postpartum depression is the most common complication after childbirth. Postpartum depression does not discriminate. It can affect all people from all races, ethnicities, cultures, and educational or economic backgrounds. Postpartum depression is defined as depression suffered by a mother following childbirth, typically arising from the combination of hormonal changes, psychological adjustment to motherhood, and fatigue, commonly diagnosed within the first 6 to 12 weeks of postpartum. Postpartum depression is difficult on mothers and their families. So when postpartum depression is not diagnosed or treated, an increased risk for adverse consequences such as poor maternal, infant, emotional, and physical attachment, leading to impaired emotional, cognitive, and language development in children. So postpartum depression is a disabling condition with the depression episodes occurring after the childbirth. Studies show that postpartum depression, it negatively impacts the maternal infant emotional and physical attachment, consequently resulting in developmental delays, also behavior and mood disorders, and abuse or even neglect. So prompt treatment will help mothers suffering from this mood disorder and manage symptoms and bonding with their baby. In a survey of 400 members of the American College of Obstetricians and Gynecologists, 36.8% of providers reported consistent use of validated screening tool. So that left 50.6% that reported they had never used a validated screening tool to assess for maternal depression. Unfortunately, postpartum depression is a mood disorder that is often unrecognized and untreated, emphasizing the need for better screening in OB-GYN care. Some medical experts believe that the rate of postpartum depression could be at least twice as much as what is reported and diagnosed. Mental health can now be seen as an illness that can be detected and treated. Because routine screening for postpartum depression is not standardized, it is often undiagnosed and subsequently untreated. Women frequently present for routine health care during the first several months of their child's life, providing ample opportunity for postpartum depression screening. However, only about 50% of women with significant depressive symptoms are recognized. Current guidelines recommended that maternity care providers conduct a full assessment of mood and emotional status at least once during pregnancy and again during the postpartum visit. A study estimated that 600,000 women were affected with perinatal depression each year in the United States, and approximately only 1/3 of them receiving any form of treatment or intervention. Diagnosis and treatment of postpartum depression are essential to the overall health of the woman during the postnatal period. So here's a chart here, just kind of give you some statistics and facts regarding postpartum depression. You see here that 1 in 7 women suffer from the postpartum depression. It also states that postpartum depression is a serious mental health problem characterized by a prolonged period of emotional disturbance occurring at a time of a major life change and increased responsibilities in the care of a newborn infant. Postpartum depression can have significant consequences for both the new mother and the family. And then there's different symptoms that are associated with postpartum depression. You have a loss of appetite, insomnia, intense irritability and anger, overwhelming fear, the loss of interest in sex, lack of joy in life, feeling of shame, guilt, or inadequacy, severe mood swings, withdrawal from family and friends, difficulty bonding with your baby, thoughts of harming yourself or even your baby. And it says suicide accounts for about 20% of postpartum deaths, and it is the second most common cause of mortality in postpartum women. Up to 50% of individuals with postpartum depression are never even detected. And also, women who have one episode of postpartum depression have 50% chance of experiencing it again with a second pregnancy. Postpartum depression can affect as many as 10% of even fathers within the first year. Within the first 24 hours after childbirth, a woman's hormone levels abruptly returns to normal. This may contribute to the postpartum depression. The review of literature. So, some of the key points of this review literature included separating baby blues and postpartum depression and how essential that it is to the care of the mother. It is also vital to identify risk factors for postpartum depression. Postpartum depression is not a weakness or a character flaw. It can simply be just a complication of giving birth. Postpartum depression screening is an invaluable aspect of postpartum care. Changes that occur after the birth of a child, such as changes in sleep, appetite, and mood, are often attributed to normal postpartum changes, causing postpartum depression to go unrecognized. Baby blues is a normative postpartum experience that occurs in 50 to 80% of women shortly after birth. Indicators typically include irritability, tiredness, and excessive tearfulness. Signs of suicide or feeling of worthlessness are not noted. Symptoms related to the baby blues are thought to fade out within the first few days to a week compared to postpartum depression, which typically lasts longer than 2 weeks. So separating baby blues and postpartum depression is very essential. Although baby blues is thought to be a normal experience in the postpartum period, evidence indicates that women who experience symptoms related to baby blues are at risk of progression into postpartum depression. So those that are having those baby blues symptoms are at a greater risk of developing postpartum depression. Risk factors for postpartum depression are identified as depression and anxiety during the pregnancy, stressful life events, traumatic birth experiences, preterm birth or infant admission to the neonatal intensive care, low level of social support, previous history of postpartum depression, and breastfeeding problems. A history of postpartum depression can lead to future episodes of major depression. History of abuse, childhood physical or sexual abuse, physical and emotional abuse by a partner, and domestic violence during childhood or adulthood are all connected to increased risk of postpartum depression. Negative life experiences in both childhood and adulthood were both common in women in postpartum depression. The combination of lack of support in close relationship, childhood adversities, low socioeconomic status have impact on postpartum depression. Postpartum depression is not a weakness or a character flaw. It can simply be a complication of giving birth. Mothers suffering from postpartum depression are often forced to cope with the feelings of inadequacy, unhappiness, change in appetite, loss of sleep, and thoughts of harming oneself or one's children. They are idealized expectations of motherhood that leave the mothers feeling guilty because they are unable to meet the expectations. Depressed mothers reported lower self-esteem, being less happy, and more dysphoric. Everyday chores such as cleaning, laundry, and grocery shopping can be difficult for these mothers to perform. Lower social functioning negatively impacts relationships with family members and friends. It is not rare for a mother who may be suffering from depression to isolate herself, wanting to be alone. Suicidal ideation is another consequence associated with postpartum depression. Higher levels of depressive symptoms are linked with increased incidence of suicidal ideation. Maternal postpartum depression present negative effects on both the child and maternal health. Efforts to screen and prevent postpartum depression are very critical. Postpartum depression screening is a valuable aspect of postpartum care. A standardized screening tool is recommended during the perinatal and postpartum period to improve early detection and treatment of maternal depression. It is evident that screening alone can provide clinical benefits by enhancing recognition of depression amongst postpartum women to improve the outcome. The most frequent used screening tool in the research and clinical setting is the Edinburgh Postnatal Depression Scale. This particular scale has been translated into 50 different languages. It consists of 10 self-reported questions that are health literacy appropriate and take less than 5 minutes to complete compared to other screenings that have at least 20 questions. Betty Newman describes the Newman system model, which is the theoretical framework that was used to frame this particular study. The Newman system model is described as a unique open system based on perspective that provides a unifying focus for approaching a wide range of concerns. In this model, the patient is viewed as an open system that responds to forces or stressors in an open environment. So the client system contains a basic structure that is protected by lines of resistance. The usual level of health is identified as the normal line of defense that is protected by a flexible line of defense. When stressors or forces from the environment break through the flexible line of defense and it is no longer capable of protecting the patient, the system moves into an illness state. A Newman system model identifies 3 relevant environmental, internal, external, and created. Several known, unknown, and universal stressors exist. Each differs in the potential for disturbing a patient's usual stability level or normal line of defense. The normal line of defense can be used as a standard from which to measure health deviation. Nursing interventions occur through 3 prevention modalities. Primary prevention occurs before the stressor invades the system. Secondary prevention occurs after the system has reacted to an invading stressor. Tertiary prevention occurs after secondary prevention has reconstitution is being established. As Newman presented in this model, the unknown, known environmental stressors after the birth of a baby may break the mother's normal line of defense, causing her to go into a state of depression. Collectively, primary, secondary, and tertiary preventions can all be applied to sustain or get back to the mother's usual stability level. Introducing a standardized routine postpartum depression screening tool will aid mothers to identify the stressors that have broken through the mother's normal line of defense, as well as allowing providers to provide the support and appropriate treatment needed. And this here kind of just shows a demonstration of the Newman's system model, where you have that core there, which is the patient, and then the line of defenses and flexible lines of defenses, and just the different stressors, the outside stressors, known and unknown, that are coming into to that core, and then your primary, secondary, and tertiary preventions. So, for this particular project, a quantitative exploratory design through a de identified screening tool was utilized for the project. Participants were not engaged, and no patient identifiers were extracted from the surveys. There were completed Edinburgh postnatal depression skills provided to the clinic for utilization of data collection. The minimum necessary data was collected to accomplish the goal of the project to get the information needed on the data collection sheet. Patients that were seen at the clinic for 6-week postpartum visits completed the Edinburgh postnatal depression scale with guidance from the staff. No patient personal information was collected, and the project surrounded a retrospective data collection. Surveys were collected for 2 months from the clinic manager. During these 2 months, providers ensured all women present for their postpartum visit completed the postpartum depression scale. After 2 months, a retrospective review of the completed Edinburgh postnatal depression skill screening tool was conducted. Each record used to project was assigned a numerical number on the data collection sheet. The population for this project was comprised of approximately 70% Caucasian and 30% from other ethnic groups, with a total of 56 participants. All participants were 18 years of age or older and female gender. The data obtained from the completed screening were collected from postpartum patients at their 6-week follow-up visit at a local women's health clinic over a 2-month time period. The quantitative method used for the particular study was the Z-test for a proportion. This one proportion Z-test was used to compare an observed proportion to a theoretical one when there were only 2 categories. Nominal categorical data was collected for this study. Nominal data is looked at as labeled or named data, which can be divided into various groups that do not overlap. Each participant was assigned a number 1 through 56 on the data collection sheet. Under the screening complete column, nominal data was consisted of 1, which equaled yes, meaning the participant was screened for the postpartum depression, or 2, meaning no, stating no screening was completed for this participant. So the outcome of women present for their postpartum visit was compared to those who were screened for postpartum depression using the Edinburgh postnatal depression scale between March 1st of 2021 and May 1st of 2021. Data was collected on patients upon completion of the Edinburgh postnatal depression scale. A completion rate of 90% was the goal. Before the completion of the Edinburgh postnatal depression scale, postpartum patients at this local women's health clinic had no depression screening in place. So before supplying this clinic with the screening tools, there were no screening in place for this particular clinic. So patients that were present for their 6-week postpartum follow-up visit were screened for postpartum depression on site. Female patients that were 6-week postpartum, 18 years or older, and present at the time of their visit for the postpartum visit were all screened. All staff that would be providing patients with the Edinburgh postnatal scale receive education and training on the screening scale. The Edinburgh postnatal depression scale were collected with the no patient identification on them every 2 weeks between March 1st and May 1st of 2021. All patients who met inclusion criteria completed the screening tool independently, but had access to staff if any questions or concerns were needed. Data was collected on patients upon completion of the Edinburgh postnatal depression scale. The study aimed to facilitate early diagnosis and treatment of postpartum depression. An upper Z test for a proportion was used to determine if the completion rate of 90% of screening for postpartum depression over 2 months would suggest that the ratio of completion rate is greater than 90% for the targeted population. While more than 90% of women were screened who were present for their postpartum postpartum visit were screened during the 2-month study, there was insufficient information to suggest the ratio of completion rate is greater than 90% for the targeted population. Researching and establishing a sample size before the start of the study would help produce an effective sample size. A sample size can easily be too large or too small to produce valuable results. The sample size for this study was insufficient and affected the results of the study. Implementing the quantitative exploratory design provides a understanding of an existing problem, but it did not provide a conclusive result. The lack of previous studies in this specific research area created limitations for the study. The measurement and data collection were based on 56 participants at a local women's health clinic, but insufficient to produce results for the targeted population. This study also lacked generalizability. The results are not for a broader group of people or situation, but rather postpartum women at a 6-week follow-up postpartum visit. The Edinburgh Postnatal Depression Scale is utilized as a postpartum depression screening tool used to help improve outcomes in patients with depression during the perinatal and postnatal period. The study aimed to facilitate early diagnosis and treatment of postpartum depression by providing postpartum depression screening to all women at their 6-week follow-up visit. An upper tail z-test for the proportion was used to determine if the completion rate of 90% of the screening for postpartum depression over 2 months would suggest the ratio of completion rate is greater than 90% for the targeted population. While more than 90% of women who were present for their postpartum visit were screened during this 2-month study, there were insufficient information to suggest the ratio of completion rate is greater than 90% for the targeted population. In addition to improvement of early diagnosis and treatment, postpartum depression screening is a cost-effective intervention and should be considered a part of normal postnatal care. The difference from screening or not screening for postpartum depression has shown great impact on the total cost, number of remissions, and quality-adjusted life years. So in conclusion, greater than 90% of women were screened for postpartum depression during the 2-month research study. There was insufficient data to suggest a completion rate of 90% of screening for postpartum depression in the targeted population. The use of the exploratory design developed a difference between what was observed and what was the expected outcome. The target of such research is to explore the problem but not truly provide a conclusion from it. Such kind of research will allow the investigator to establish a solid foundation for exploring the hypothesis, choosing the correct research design, and identifying variables that are imperative for the analysis. For future research and improved outcomes, a pre-test post-test design over 1 year would be implicated. The execution of routine postpartum depression screening and clinical practice will decrease the cost of medical care, delivery of appropriate care, improve infant-mother bonding, and detect postpartum depression early enough to sustain the mother's quality of life. And let me know if you have any questions, concerns, or recommendations. Thank you.